early in 10 weeks of gestation. This shows an example of 12 cases of babies and a 3-hour scan, because we draw blood before doing cell-free DNA. Women in Melbourne, they want their cell-free DNA as early as possible. And we do a scan to make sure that it's alive, because it's an expensive test, before we draw blood. If you look at these cases, you'll see all of them have an omphalocele. Here, here, loop of bowel, 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 and it's getting worse as you come down from the top left-hand corner to the bottom right-hand corner. And the more bowel that's in the base of the cord, the more concerning it is. And you say, Simon, are you worried about any of these babies? I'm saying, no. It's only 10 weeks. Because in most babies, bowel migrates into the base of the umbilical cord, rotates 270 degrees, and then returns to the fetal abdomen. But sometimes they're very striking, Simon. And how do you know whether it's normal or whether it's actually truly an omphalocele? For example, 10 weeks and 2 days, and you see a baby that's got a large herniation of bowel into the base of the cord. Is that physiological or pathological? Look at this case. I thought this was gastroschisis because I saw multiple loops of bowel and it was lateral to the cord insertion site. I didn't say that to the patient at the time. I didn't say I think the baby's got gastroschisis because I've never made a diagnosis of gastroschisis before 11 weeks in 30 years of practice. Omphalocele, yes, plenty, but not gastroschisis, because I think it happens later. So when you look at this baby with loops of bowel, that's the cord, and the loops of bowel are lateral to the cord insertion site. When I bring the patient back, that was at 10 weeks, I bring the patient back at 12 weeks and 1 day, now look at the cord insertion site. And you look at the level of the vein. There's no bowel in the base of the cord, it's returned. So you say, Sam, okay, what measurements do I take to help me? I'm beginning training, I want some guidance. This is the chart, you can take a picture of it. It gives you the width of the cord insertion site, in the 50th centile and the 95th centile. And it also, if you want to do it, you can calculate it using a volume. And by using these cutoffs at 8 weeks, 9, this is the important one, 10 weeks. These are the figures which may help you whether you're looking at the 95th centile or whether your volume is above 95th. Personally, I don't use this. I go on subjective assessment. But for those of you in training, you need to have a cutoff. Because when I did this scan at 10 weeks and 6 days, I knew that this was not physiological. I had another clue. It was an increased leucine. When I looked at the herniation of the bowel into the base of the cord, I always ask, is it liver? And if it's liver, then I know it's not physiological, because the physiological herniations are not liver, they are all bowel. So if I track the intrahepatic portion of the umbilical vein and it goes through this, that tells me that that's liver. And sadly, in imaging, I've got another clue, there's an increased mucopolysaccharidosis, and this is a very on the 18. So these groups of omphalocele major, many of these are missed on prenatal ultrasound. Why? Because we don't magnify the image of the cord, and we don't look at the level of the vein. The two arteries come in inferiorly, and the vein is superior. It's at the level of the vein that you can magnify, getting to the point where the cord inserts into the abdominal wall. That's where the hernia is. And it can be a single loop of bowel, and 3D with VCI will help you make sure, because you can track the outline of bowel, and it looks exactly the same as the outline of bowel in the abdomen. Where liver is more isochoric or hypochoric. This, I know, is a liver herniation. And this is both liver and bowel, because I can use 3D VCI. I can see this is the liver, and this is the bowel above it, by using 3D technologies. Be careful, because in this baby, you see a herniation of bowel into the base of the cord, and you say, okay, it's an omphalocele minor, okay, she's 13 weeks, okay, there's nothing else, okay, the mucopolysaccharidosis is thin. What do? You offer a coronal biopsy, because you know an omphalocele minor is associated with chromosome abnormalities, and you offer chromosomal microarray. If it's isolated, it doesn't matter because there's nothing else there. as long as she's after 13 weeks of gestation, according to, or 12 weeks to the ECO guidelines, 13 weeks to the American guidelines. But there's another important point to make, is that when you see the loop of bowel in the base umbilical cord, don't stop there. Is track the bowel, and you may find that the bowel goes a long distance down the cord. Bow, 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 and now you travel down the cord. Bow, bow. In fact, there's more bowel further down the cord than there is proximally. So what do I do next? I go to sagittal section and I track the bowel, and it goes all the way down the cord. Why is that important? Because when the baby's born, if you put a clip on there, you will clip the bowel, and the baby will end up having surgery as a result of that. And therefore it's very important that you give a very clear instruction where you place the clip. And therefore every omphalocele that you see, you need to find the distal point of where the omphalocele is. Not just make the diagnosis, to find out where the distal point is. Okay, omphalocele major, much more easy, very straightforward diagnosis. I mentioned, look at the circumference of the omphalocele compared to the abdominal circumference. If the omphalocele is the same, that's the omphalocele. If the omphalocele is larger than the abdominal circumference, this baby is going to need a two-stage operation repair, not one. If your omphalocele is smaller than the abdominal circumference, then there will be a single operation repair on published data from Asma Khalil in the UK. So prognosticating omphalocele in the first trimester is important. And of course, you see increased nuchal fluid, scoliosis, associated abnormalities. The prognosis is worse for these babies, and you need to cancel the parents accordingly. So, if you look at this baby here, bowel here, liver here, this is the point here, and you look at where the cord inserts. Typically, the cord inserts into the apex of the hernia, and that's one of the distinguishing features in how you work it out from a gastroschisis. But with current day technology, I think it's a very straightforward diagnosis, distinguishing an omphalocele from a gastroschisis. But when I was training, the exam question was, Simon, how do you tell between gastroschisis and omphalocele? Was it a cord insertion into the apex tells me it's omphalocele. Anyway, I just mentioned it. With regard to omphalocele, I always worry about them because of Beckwith-Wiedemann syndrome. So you say, Simon, when you see an omphalocele in the first trimester, you do a chorion biopsy. Can you send a chorion biopsy for methylation studies for Beckwith-Wiedemann? No, you can't. So you have to bring the patient back again, yes. And do an amniocentesis, yes. So you have to needle the patient twice, yes. I do the CBS to get the result of the chromosomal microarray. I do the amniocentesis to do methylation studies. And then you say, be careful, because if you're doing two procedures, then there's an increased risk of losing the pregnancy. Well, then you may, at the very beginning, you may say to the patient, do you want testing for Beckwith-Wiedemann? If the patient says, if the baby is Beckwith-Wiedemann, I'm not worried about that. You cancel it. You tell her what Beckwith-Wiedemann syndrome is. It's not a major deal. Patient says, I don't care about Beckwith-Wiedemann. You can test after birth. If they say, no, Beckwith-Wiedemann, I want to know about Beckwith-Wiedemann. I want to know about it as early as possible. And the amniocentesis is 15 weeks, and don't do a chorion biopsy. So that's a very important point in managing, and that is not clear in the literature that's published to date. So if you want to take a picture of that slide, it gives you the yield. So if you have an omphalocele, about 50% of these you'll find will have associated abnormalities, exclude those. 30% of them will have aneuploidy. Only 1% will have microdeletion duplication, and the remaining 10 to 20% will have Beckwith-Wiedemann. So remember. Also, when you scan these babies, you'll find frequently there's a cord insertion site, there's your omphalocele. Quite frequently obstructs the lymphatics, and you get this very dilated looped cord. Don't worry too much about these. Just check that your blood flow studies are okay. But some of these babies with omphalocele can obstruct the lymphatics in the cord. Okay, I have a trick question for you. I'm coming to the end of the talk. What type of omphalocele do you think this is? It's a trick question. The doctor gives you a clue. What do you think? Anybody? a leg and a leg. Trap sequence. So trap sequence features can look like an omphalos. So this is a baby as you come down here, directly attached to this fetus here, with 2 feet hanging off the end of the omphalos. When I was a junior in training, I made a diagnosis of omphalos back in 1995, 1996. At 20